Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Some doctors say statins are so good that almost everyone should take them to prevent a heart attack, but not everyone agrees. This is the People's Pharmacy with Terry and Joe Graydon.
We explore the statin controversy with two prominent cardiologists. Dr. Steve Nissen of the Cleveland Clinic is a statin enthusiast. Dr. Rita Redberg, editor of JAMA Internal Medicine, is more cautious. What can you do to keep your heart healthy?
Do you know the difference between heart disease and heart failure? Find out about the symptoms and the latest treatments for congestive heart failure.
Coming up on the People's Pharmacy, the Statin Standoff and how to recognize and treat heart failure.
First, this news.
In the People's Pharmacy health headlines, popular heartburn drugs like esomeprazole, lansoprazole, or omeprazole may not be as innocuous as they might seem. These proton pump inhibitors, or PPIs, are better known by their brand names, Nexium, Prevacid, and Prilosec. Over the past several years, a number of serious adverse effects have come to light. They include an increased risk of infections such as pneumonia and Clostridium difficile, weakened bones, poor absorption of nutrients such as calcium, iron, magnesium, zinc, and vitamin B12, heart attacks, kidney disease, and dementia. Investigators used a large database of more than 3 million VA patients to determine that PPIs increase the likelihood of death over a 6-year span. The scientists used patient records to compare people who had received a new prescription for a PPI to those who did not take any acid-suppressing drugs, as well as to those who took a different, less powerful acid-reducing medicine such as cimetidine or ranitidine. They found that people taking PPIs were about 1/4 more likely to die during the study. No one should stop a PPI suddenly, as that might trigger rebound hyperacidity and severe symptoms of indigestion. The authors of this paper in BMJ Open suggest that PPIs should be used for a limited amount of time and only when there is a clear medical indication and where benefits outweigh risks.
Low levels of vitamin D in the blood are linked to increased mortality. That's the conclusion of a large population-based Norwegian study. Investigators followed over 6,613 adults over nearly 2 decades. Participants completed questionnaires about lifestyle, socioeconomic status, and chronic diseases. During clinical examinations, they were weighed, measured, and blood was drawn for later analysis. Over the 18-and-a-half-year follow-up period, 1,539 people died. Those with the lowest levels of 25-hydroxy-vitamin D in their blood were roughly 30% more likely to have died compared to those with the highest levels. This correlation persisted regardless of chronic diseases at baseline. The authors point out that the results of this study were similar to other investigations.
Testosterone is thought of as a male hormone, but women also make this androgen naturally. A new study in the British Journal of Sports Medicine reveals that elite female athletes who have naturally high levels of testosterone perform better than those with normal androgen levels. Hyperandrogenic disorder of sex development can produce abnormally high levels of testosterone in women. The investigators analyzed data from the 2011 and 2013 track and field world championships. Although the improvements in events such as pole vault, 400-meter hurdles, 800-meter runs, and the hammer throw were modest, at this level of competition, even a small advantage can lead to a championship.
Clostridium difficile infections can cause life-threatening diarrhea. Experts estimate that 500,000 people contract C. diff infections annually, and nearly 30,000 die. Once people develop C. diff, they're at risk for recurrences. A new study in the Annals of Internal Medicine shows that multiply recurrent C. diff infections have increased by 189% in the last decade. The authors note that recent use of antibiotics, corticosteroids, or PPI-type acid-suppressing drugs are potential risk factors for such repeat infections. Treatment with antibiotics becomes less effective for these patients. Instead, doctors are beginning to employ fecal microbiota transplantation, even though it's expensive and relatively unregulated.
Uncorrected hearing loss can contribute to social isolation, but in the U.S., hearing aids are extremely pricey and not covered by insurance. That helps explain why only about 1/5 of the adults who could benefit from hearing aids actually use them. There's now a second option, known as personal sound amplification products. These over-the-counter devices are less expensive and not labeled for hearing loss treatment. But might they help? A small study reported in JAMA compared the performance of 5 of these devices to that of hearing aids. The scientists found that 3 of them were almost as effective as actual hearing aids, but one didn't help much, and the least expensive was worse than nothing. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. You've heard many times on this program that a healthy lifestyle is the best way to reduce your risk for heart disease. Many distinguished cardiologists have emphasized the importance of regular exercise. A diet full of vegetables and fruits and low on meats and sweets is also beneficial. What's contentious, however, is drug treatment to lower cholesterol.
How low should it go? Which cholesterol-lowering drugs are best? How much will statins reduce the risk of a heart attack? Even the world's leading experts in cardiology can't always agree.
Later in the show, you'll hear from cardiologist Rita Redberg. She's professor of medicine at the University of California, San Francisco, and director of the UCSF Women's Cardiovascular Center. She's also editor of the journal JAMA Internal Medicine.
But first, we turn to Dr. Steve Nissen. He's chair of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. Dr. Nissen is a past president of the American College of Cardiology and former chair of the FDA's Cardiovascular Renal Drugs Advisory Committee.
Welcome to the People's Pharmacy, Dr. Steve Nissen.
It's great to be with you again.
Thank you, Dr. Nissen. We have been following this very intriguing story for a couple of years. It has to do with a new class of cholesterol-lowering drugs. And there was a study just published recently in the New England Journal of Medicine. Terry, it has an interesting name.
The name is Fourier, which is a name for a sort of mathematical concept or strategy.
And it stands for the Further Cardiovascular Outcomes Research with PCSK9 Inhibition in Subjects with Elevated Risk. Whew, what a mouthful. What was going on?
Well, this is an important study. When I was in medical school, I was taught that a normal cholesterol was anything under 300, normal total cholesterol. It's astonishing to me, but that's what we were taught. And over the years, we've learned with first the statins and now with other drugs that lower levels of the bad cholesterol, that's LDL cholesterol, are associated with a reduced risk of heart attack and stroke, and in some cases and in certain patients, a lower risk of death. But we never had information on whether or not this new injectable type of cholesterol-lowering drug would, like the statins, would reduce the risks of these adverse outcomes. Fourier is the first of the trials. And by the way, that name relates to the fact that all the trials with this particular drug are named after famous scientists. So that's the link to Fourier. Now, what they did was a really pretty interesting study. It's huge. It's 27,500 patients. And half of those patients got a statin, mostly in high doses, and they got their LDL cholesterol to a level that's considered by most people to be reasonable. These are all people that have existing heart disease. These are not healthy people. These are people that have heart disease.
Many of them had heart attacks, right?
Many of them had had previous heart attacks or strokes or bypass surgery. I mean, a variety of different, forms of coronary heart disease. And the group that got the statin alone had a bad cholesterol, an LDL cholesterol of about 90, which is considered to be reasonable by most standards. The group that got the statin plus a PCSK9 inhibitor, these injectable cholesterol-lowering drugs, had an LDL cholesterol that was astonishingly low. It was only 30 milligrams per deciliter, 30. This is lower than we've ever gone before. And the question was, would there be an incremental benefit? And what we saw in the trial was that on the primary endpoint that was studied, which was 5 components, death, heart attack, stroke, hospitalization for unstable chest pain, or the need for a stent or bypass, that was reduced by 15%. For the more important endpoints, what we call hard endpoints of death, stroke, heart attack, it was a 20% reduction. Importantly, however, it was heart attack and stroke that were reduced, not death. There was not a reduction in death, but there was a reduction in heart attack and stroke. It's a landmark study because it goes so low. And interestingly enough, we worried about the safety of taking cholesterol levels that low, and there really were not any apparent safety problems in doing so.
How did you determine that? Because that's something that definitely occurred to me. As you take cholesterol levels below where anyone can get, naturally.
Well, yeah.
Is there a consequence?
Well, that's right. And so the investigators, and these are very good people at the Brigham in Boston, excellent research group, they collected all the adverse effects, and it's just about the same in both the group that was at 90 and the group that is 30. But please keep in mind that primitive populations, wild mammals, newborns and infants, not uncommonly have cholesterol levels this low. So many people believe that when we lower cholesterol levels to 30 or 40, we're just getting back to the levels for which as a species we're biologically adapted, and that we've just become so used to seeing levels that are very, very high. That's a reflection of the modern Western lifestyle, diet, obesity, and all the other things. We're really kind of getting back to where nature wants us to be, which is with a very low level of cholesterol.
Well, Dr. Nissen, using the anthropological argument is definitely going to make an impact on me as an anthropologist.
Yeah.
Now, I do need to hold your feet to the fire, Dr. Nissen, because you've mentioned something called relative risk reduction. You mentioned 15% and 20% relative risk reduction. We also like to talk about absolute risk reduction. So in theory, I would have expected the people who had been able to get their LDL cholesterol down around 30 or lower, which, as you say, is unprecedented, wouldn't have had any heart attacks and would have been able to defy death for years. That wasn't the case. So what was the absolute risk reduction? We see 11.3 versus 9.8. So 1.5 person out of 100 got benefit from Repatha. Could you fill us in on that?
Absolutely. It's actually 1 in 74 patients. You avoid an event in 1 out of every 74 treated patients. That's pretty typical of most studies. Cholesterol is for life. This was a study that was a little bit longer than 2 years. We're not going to wipe out heart disease by lowering cholesterol to these very low levels for just about 2 years. But let me tell you about a very important study that was one that led to the development of this class of drugs. It was the Dallas Heart Study, where they looked at people that had a natural genetic variant that lowered PCSK9, that's the protein that's being treated here, but by the natural genetic difference that these people had from the rest of the population. These individuals had about a 17% lower lifelong cholesterol level, and they had an 88% lower risk of a major cardiovascular adverse outcome. So if you lower cholesterol level for life, you can produce dramatic reductions in heart disease. But if you do it for just 2 years, the effect is more modest. I would have liked the study to have gone longer, because what we saw in this recent study, Fourier, is in death, stroke, heart attack, a 16% reduction in the first year and a 25% reduction in the second year. What would we have seen in the third year? We don't know, because the study was stopped after just about 2 years.
Dr. Nissen, one of the features of evolocumab, Repatha, is that it's very pricey. Will insurance companies be covering it?
I think they'll cover it for more patients. And let's be clear, this is not a therapy for everyone. It's certainly not a therapy for people that are worried about developing heart disease. These were all patients that have a very aggressive disease. They've had events. They still have LDL cholesterol levels that are not as low as we would have liked. The higher the risk, the more this makes sense. And people with certain genetic forms of high cholesterol, we call a familial hyperlipidemia, these people look like they're going to get the most benefit. I think insurers are going to pay for the therapy for people that are at very high risk. But the study helps us make the case with insurers that for certain of our high-risk patients, that there's a benefit to be accrued by getting their cholesterol levels down to these very low levels. If they've been tried on the most effective therapies that we have, and they're still not as low as we need them to be, this adds another tool in the tool chest to try to tamp down the risk of recurrent heart disease in people that already have heart disease.
Dr. Steve Nissen, thank you so much for explaining this to us today.
It's always a pleasure.
You've been listening to Dr. Steve Nissen. He chairs the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at Cleveland Clinic's Seidel and Arnold Miller Family Heart and Vascular Institute. You can find a link to the Fourier study that Dr. Nissen was discussing from our website, peoplespharmacy.com. Dr. Nissen has served as president of the American College of Cardiology and chair of the Cardiorenal Advisory Panel of the Food and Drug Administration. He's the co-author with Mark Gillinoff of Heart 411, the only guide to heart health you'll ever need.
After the break, we'll talk with Dr. Rita Redberg about the statin controversy.
How good are drugs like atorvastatin or simvastatin for preventing heart attacks in healthy people?
Dr. Redberg explains some confusing statistics.
We talk about shared decision-making regarding statins. What does that look like?
You'll also learn about congestive heart failure, which is something quite different than blocked coronary arteries.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339, online at uttercream.com.
If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1085. That number again, 800-732-2334, or visit our website, peoplespharmacy.com. You can also download the podcast for free at iTunes.
Today, we're talking about heart disease. We've heard from Dr. Stephen Nissen about ways to keep cholesterol under control with medications. Dr. Nissen is a statin enthusiast. He believes that getting LDL cholesterol as low as possible is important for heart attack prevention. Not everyone agrees, however, that statins are the key to success. In fact, statins have become rather controversial, even among some cardiologists. For a different perspective, we turn to Dr. Rita Redberg.
Dr. Redberg is professor of medicine at the University of California, San Francisco. She's a cardiologist and director of the UCSF Women's Cardiovascular Center. She's editor of one of the world's preeminent medical journals, JAMA Internal Medicine. Dr. Redberg has written some provocative articles with colleagues about saturated fat, cholesterol, and statins. Her editorial in JAMA Internal Medicine reflects the controversy around statins.
Welcome back to the People's Pharmacy, Dr. Rita Redberg.
Thanks. I'm glad to be here.
Dr. Redberg, you had a very interesting article in JAMA Internal Medicine, of which you are the head editor, titled Statins for Primary Prevention. The debate is intense, but the data are weak. I wonder if you could tell us why there is such polarization in medicine, especially in cardiology, over statins and heart health.
Well, yes, it is a very controversial area. I think there's a lot of polarization because it's a very common problem. There's not a lot of data that informs it. And quite frankly, there's a lot of money in statins for primary prevention. So for all of that reason, it's getting a lot of attention.
Well, when you say primary prevention, we're talking about preventing heart disease in people who are healthy now, who don't already have heart disease. Can you tell us about the pros and cons of using statins for that purpose?
Sure. So statins, as you know, lower your cholesterol. But the question is, do they also, besides treating a lab value, which is all you're doing by lowering your cholesterol, do they also make you healthier in some way or more likely to live longer? Okay, they certainly don't make people feel better. They do lower cholesterol, and the best estimates are that in 100 people that take statins for 5 years, 1 or 2 of them will avert a heart attack over that 5-year period. None of them will live any longer. So, although they will have their cholesterols lowered. So that means that 98 of those 100 people who are taking statins will have absolutely no benefit, but they are exposed to all of the harms and side effects of taking statins. And those are numerous, including muscle aches and pains, kind of general fatigue and malaise, memory loss, diabetes, and then a lot of other things that have been reported. When I'm advising patients on how to reduce their risk of heart disease, I stick with things that I know work and don't have side effects, like healthy diet, like a Mediterranean-style diet, getting regular physical activity, whatever you can do, and not smoking. And we know those things will help you to feel better, reduce your risk of heart disease, and even help you to live longer. And they don't have the side effects.
Dr. Redberg, a lot of our listeners are very confused because there was something called the United States Preventive Services Task Force. They reviewed 19 trials, 71,344 patients, and basically they concluded that everyone between 40 and 75, even if they had no history of cardiovascular disease, but just had, let's say, higher cholesterol, and maybe a risk of 7.5% over 10 years, that they should all be on statins. And we've heard from an awful lot of cardiologists who say, I just put everyone who's over the age of 65, especially if they're a man, on a statin because that's what the American Heart Association and the American College of Cardiology say they should be doing. They should be on a statin. And people read that it reduces their risk by 30 to 40%. which sounds a lot different from what you said of maybe 2 out of 100 will reduce their risk of a heart attack and nobody will actually live longer. Can you explain why there's this confusion, 30 to 40% versus maybe 1 or 2 out of 100?
Right. And I agree with you, that is confusing. And really, we're talking about the difference between absolute risk, which is what I gave you, and relative risk, which is what you're quoting. So, for example, if you go from 3 people in 100 that would have a heart attack over 5 years to 2 people in 100, that's, I think, a 50% reduction. So that's where you would get. Now, that sounds much more dramatic than saying that's 1 person in 100 difference over 5 years. But that's where some of the confusion comes in, is that the relative risks that are often used in headlines and in the media are very misleading because they're very unlikely to apply to any one person.
There's another number that's also very confusing to our listeners, and I think even to some health professionals, and that's what's called the NNT, the number needed to treat. And it's my understanding that if you're relatively healthy, but you have high cholesterol, and if you were to take a statin, that it would be 1 person could prevent a death out of 244 people. In other words, 244 otherwise healthy people would have to take a statin in order to prevent 1 death. Is that really true?
So, again, the data differs, but probably the most favorable estimates that we've seen on statins would say you would need to treat 244 to prevent 1 event. It's just another way of, it's actually taken from the same numbers that we talked about earlier, that 30 or 40% reduction. When you calculated it, there's just a formula on how many people are needed to treat. But I think the idea is important because I think most people taking statins think they are definitely getting a direct benefit, and it's just not true. I mean, their cholesterol is being lowered, but they're not getting a benefit in terms of improved health or living longer.
Well, Dr. Redberg, you and your co-author on this editorial, Dr. Katz, suggest that patients and doctors should be participating in shared decision-making when it comes to statins. I wonder if you can tell us a little bit about what that is and what it would look like.
Sure, exactly. And a lot of it is, I think, where the task force was going and what I was suggesting. The numbers that we have discussed a few minutes ago are the kinds of conversations that one should be having. And honestly, the conversations I'll have with my patients, I'll say, this is the data. This is what we know about statins. The benefits are that in 100 people who take statins for 5 years, 2 over that 5-year period will avoid a heart attack. And then this is what we know about the risks of statins. And these are other ways that, like the lifestyle changes that we talked about, that you can do now to prevent heart disease. And, it's up to you. If you feel that you want to be taking a statin, you certainly can. But there are a lot of people that don't want to be taking a medicine, particularly if they can just make very simple lifestyle changes and be even better off. But they're under the false impression that their life will be saved if they take a statin. So that's what shared decision making is getting the actual data on risks and benefits for that person, the alternatives, and then making a decision on what's the right thing.
Dr. Redberg, there are some people who feel as if they don't take a statin, they're going to be letting their doctor down. They'll disappoint their cardiologist. And some cardiologists get pretty upset if their patients won't take the statin. How should a patient respond in that situation?
Yeah. I understand, and I think that is a difficult situation. In general, none of us want to disappoint our doctors or feel like we're not taking the doctor's advice. And I think that's difficult. That's why, we wrote this editorial, obviously, in JAMA, which is a medical journal because it's an important message, we think, Mitch Katz and I, for doctors as well as for patients, because I think there is a feeling that there's a lot more benefit to statins than the data actually suggests. And, every week in my cardiology practice, I see patients who are really miserable because they're trying to follow a doctor's advice to take statins, and they're having a lot of side effects, and they feel like if they stop, either something terrible will happen or their doctor will be upset. I've had patients that I've seen for second opinions who told me that their doctor got so angry when they got my letter recommending that they should discontinue their statin that they ripped up the letter and told the patient they would need to find another doctor. So I understand that that's a very difficult situation for people to be in. And we hope that more education, on the actual risks and benefits can help to alleviate putting patients in that position. But you're right. We started out saying this is a very controversial area, and I think that that's what leads to a lot of that confusion.
Yes, indeed.
So there's a lot of, unfortunately, conflict of interest associated with this. As we've said, statins are a billion-dollar market. The guidelines have a lot of, not the U.S. Preventive Services Task Force, which has a strict conflict of interest policy, but the American College of Cardiology and American Heart Association guidelines had issues with conflict of interest. The studies that have been done on statins to date are almost entirely industry-sponsored. The data is not publicly available. The data on adverse effects has not been released for most of those studies. It's not publicly available. It's all held, a lot of it, by the group in Oxford, the cholesterol trialists, that said 2 years ago they were going to make all the risk data publicly available, but still have not. And so there are a lot of problems with, I think, for a drug that's been out over 20 years, we have surprisingly little data on harms.
The question of conflict of interest is one that patients really don't have a good way to learn about, and yet it has fostered, I think, a lot of suspicion among certain patients, wondering if their doctor, perhaps, is somehow experiencing a conflict of interest.
I think that's true, and I've heard people suggest that doctors should post in their office, if they are taking money from particular companies or funded by some of the pharmaceutical or device companies that make products they're recommending. There is open payments available, which is on the CMS website, where you can look up any of your doctors, but I don't think most patients do that, and it certainly would be an uncomfortable conversation.
Dr. Redberg, you mentioned this is big business, and there's now a whole new class of cholesterol-lowering drugs that are quite extraordinary. The most recent was published in one of the journals called Repatha. It lowers LDL cholesterol to levels that we've never seen before, to 30 and even below that. It's an expensive drug, estimated around $14,000 a year. It requires an injection every other week or so. Any thoughts about this class of drugs and where they fit in things, especially for people who may be experiencing side effects from statins?
I think we're just starting to learn about those drugs. There were some of the outcome studies were published a few weeks ago and released at the American College of Cardiology meeting. As you said, they showed dramatic reductions in LDL. They did show a reduction in heart attacks, but they showed no benefit on cardiovascular mortality or on all-cause mortality. And in fact, the people that were taking those drugs had a slightly higher rate of dying than the people not taking those drugs. So, I think, as I said, we're just starting to see data. I think we continue to collect it and need more data on long-term outcomes. It's not clear why there was a benefit seen in heart attacks but not seen on cardiovascular mortality, because those would be expected to track together. So I think it's a class we'll be learning more about in the next few years. And you're right, currently they're very expensive. Again, that was an industry-sponsored trial where the industry collected the data, chose the sites, and helped with the writing of the study. The analysis was done independently by the Harvard investigators for that trial I was just referring to. But I think those drugs are most clearly beneficial now for people who have a very rare condition called homozygous familial hypercholesterolemia. I don't think they're currently being recommended for people that are statin intolerant, but it's all evolving as we learn more and collect more data.
Most Americans, Dr. Redberg, don't really understand the difference between heart disease and heart failure. I wonder if you could kind of summarize it and where we stand, because it's my understanding heart failure is increasing at a rather substantial rate, and it can be a killer just as much as heart disease can.
So heart failure means there is a weakness of the heart muscle so that it's not pumping out the blood normally from your heart. And that the most common cause of heart failure is from heart attacks or coronary artery disease. And that has actually been declining in the last decade. But there's now a new kind of heart failure that's called heart failure with preserved ejection fraction, where people have symptoms of heart failure like shortness of breath or getting up in the middle of the night feeling short of breath, but their heart muscle function is actually normal. The prognosis for that kind of heart failure is much better. It's not like the kind that I told you about when the heart muscle is weakened. And that, again, is something that has been increasingly diagnosed. There's not a clear treatment for it right now, and there's just a lot of research in that area.
Dr. Rita Redberg, thank you so much for talking with us on the People's Pharmacy today.
My pleasure. Bye-bye.
You've been listening to Dr. Rita Redberg. She's a cardiologist and director of the UCSF Women's Cardiovascular Center. She's editor of one of the world's preeminent medical journals, JAMA Internal Medicine. Dr. Redberg is professor of medicine at the University of California, San Francisco. She's written some provocative articles with colleagues about saturated fat, cholesterol, and statins. You'll find links to her editorial on statins and her article on saturated fat from our website, peoplespharmacy.com.
We need to take a short break. When we come back, we'll learn much more about heart failure.
We'll find out how many people suffer from heart failure and why it's so dangerous.
Not everyone knows the difference between heart disease and heart failure, but the distinction is extremely important.
How difficult is it to diagnose heart failure?
Do people fare better if the diagnosis of heart failure is made earlier rather than later? And what are the early warning signs that patients and families should be looking for?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red-X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. 800-345-7339. Online at uttercream.com.
To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1085. That number again, 800-732-2334, online at peoplespharmacy.com. You can also download the free podcast from iTunes or from our web store. We invite you to consider writing a review.
Today, we're talking about heart disease, heart failure, and new drugs to treat them. As we were talking with Dr. Redberg, she mentioned heart failure. we don't often speak about heart failure, which shouldn't be confused with heart disease.
To help us understand heart failure, we turn to Dr. Alan Maisel. He's professor of medicine at the University of California, San Diego, and director of the Coronary Care Unit and Heart Failure Program at the Veterans Affairs San Diego Healthcare System.
Welcome back to the People's Pharmacy, Dr. Alan Maisel.
Well, it's nice to be back with you.
Dr. Maisel, we're talking today about congestive heart failure, and I would hazard a guess that most of our listeners have very little idea of what we're talking about. When they hear about heart stuff, they think heart disease.
Or heart attack.
Clogged coronary arteries. But what the heck is heart failure? How big a problem is it? And why should we care?
Well, those are great questions, and you're absolutely right. Now that people are living longer, they're surviving heart attacks. There's an increase in obesity in our society that leads to insulin resistance and decreased heart function. Heart failure has become an epidemic. And in fact, right now there's almost 6 million people in the United States who have heart failure, which I will define in 1 second. 800,000 new cases, and it is projected to increase almost 50% from 2012 to 2030. So it'll be 8 million people or more. And in fact, back when last time they looked in about 2009, 1 in every 9 deaths included heart failure as a primary or contributing cause. And if you get heart failure, well, it's like getting cancer. About half the people who develop heart failure die within 5 years of diagnosis, and that's actually worse than cancer. And as far as monetarily wise, we're talking $32 billion in direct costs each year. So it's there. It's an epidemic. But like you said, it is not coronary disease necessarily or vascular disease. It's a progressive clinical syndrome. It results from structural or a functional impairment of the heart, either how it doesn't fill well or it doesn't contract well. And this could be from long-standing hypertension. It could be from a heart attack. It could be from a virus. It could be from drinking. It could even be from certain drugs, which we can get into. Very common, the methamphetamines causing an epidemic out here on the West Coast. But people who present with heart failure, almost all will have some kind of shortness of breath and fatigue, and then will often have fluid retention.
Dr. Maisel, there are a lot of people who die from heart failure, and we see it in the obituaries and in the newspaper, but again, I don't think it registers. I think a lot of people are assuming, they died of a heart attack. So we're talking Nancy Reagan, Charles Darwin, Eleanor Roosevelt, Elizabeth Taylor, Jimmy Stewart, Dwight Eisenhower, Florence Henderson, and George Michael. That's just a fraction of the number of, superstars, people we know about who die of heart failure. It seems as if it has gone, I won't say unnoticed, because certainly you and your colleagues are aware, but why haven't the American public appreciated how serious heart failure is, do you think?
Well, it's a great question, sometimes a little bit puzzling. I think it's probably even underestimated because, about 30 to 40% of patients with heart failure will die suddenly from an arrhythmia, and they will sort of drop dead where they're at. And oftentimes that will get recorded as a heart attack or primary arrhythmia when the real cause, part of the natural order disease of heart failure, when the heart gets stretched and it doesn't work, you get electrical dysfunction and you can die. So we're even underestimating that. But I do think that heart failure is beginning to get more notice, in part because heart attacks are going down, cholesterol is being extremely well treated, and then thank you to the state-of-the-art advertising, there are several new drugs out. The one you see on TV every single day now is Entresto. We can talk about this in a while, but it's one of these brand new medications that looks like it will be very good. So people are learning about heart failure through the wisdom of our pharmaceutical companies, if you will. And I think we are learning more and more, and this will become part of the vernacular of people that are conscious about their health and preventing deterioration of heart function.
Dr. Mazel, we've just described that people are only now beginning to appreciate the seriousness of heart failure. How difficult is it to diagnose heart failure?
Well, the symptoms of heart failure are quite nonspecific. You know, when I teach this at the med school, I ask the students, okay, how many here have had some shortness of breath on exertion? And of course, they all raise their hand. How many people have felt very fatigued? They raise their hand. How many people get up in the middle of the night to go to the bathroom? They raise their hand. How many have felt palpitations? How many get swelling in their legs? And quite a few do, especially if they're standing up a lot of the day. So you need to put all this together, and the physician, the primary care, usually is the first one to see the physician, or it could be in the emergency department where they present with really bad shortness of breath. They will do a history about this progressive shortness of breath, maybe some swelling or what we call edema. They can't lay down at night because blood fills their lungs, and they get shortness of breath, so they end up sleeping on several pillows. And they put together the history and the physical examination, and then now we have some blood tests. I helped get one of these blood tests approved, and it's now used all over the world. The main one is called the BNP test. B stands for a B-type natriuretic peptide. And this is a simple blood test that is released when the wall stress of the heart is elevated, when the pressure is high. When the pressure in the heart is high, the pressure backs up from the left heart right into the left ventricle, left atrium, and then in the lungs, and you get short of breath. And if it goes on for too long, it will then back up from the lungs to the right heart, down into your legs, your liver, and you'll get congestion, you'll get a lot of fluid in the heart. So this blood test, normally the BNP, there's a BNP, and then there's one called N-terminal proBNP, pretty much the same test, but two different lab values. But there's a level, if you come to the hospital or the doctors with shortness of breath and it's low, well, we are about 95% sure the shortness of breath you have is not from heart failure. That's great. But then the other side of this, it sort of becomes like a PSA test. You can rule it out at low values, and it will rule it in at very high values, but in between there are some other things that could cause elevations. And so it's not just the BNP test, it's a chest x-ray, and then it's an echocardiogram, which is an ultrasound of the heart.
Well, let's go back and talk about those symptoms, because
Sure.
You mentioned that, even when you're teaching medical students, people will say, well, yeah, sometimes I have edema in my ankles, and sometimes I get shortness of breath. But what would be the quintessential list that people should look at? I mean, if they see the elastic on their socks at night before they climb into bed, that little indentation, I mean, is that something to get worried about?
Sure.
If they climb a set of stairs and they're starting to huff and puff by the time they get to the second floor, is that worrisome? I mean, when does it... a red light that says, go see your doctor and ask about heart failure?
Sure. It's a great question, and the most common symptom, which we can explore, is, we call it dyspnea, which is shortness of breath. Now, everybody has this, but what we look for is a progressive shortness of breath. Well, George, you said you can't mow your lawn now. When was the last time you could mow your lawn? Or last Christmas, how many blocks were you walking, and how many do you do now? A progressive worsening in the amount of activity, undue fatigue, is often a symptom that could be from poor cardiac function. The other one, actually one of the earliest symptoms that we see, although not totally specific for heart failure, is what we call nocturia. And that is getting up at night to go to the bathroom to pee. And what that means is that when you lay down at night, the fluid that you're accumulating in your body, the extra fluid and the extra salt, is stretching the heart. And it's actually by stretching the heart, making it almost like a rubber band effect, making it pump better to the kidneys. And you actually then have to go to the bathroom. So people sometimes say, I don't know, Doc, I can't mow the lawn as good. I'm getting up 2 or 3 times a night to go to the bathroom, and oh yeah, gosh, my my shoes are a little tight and my socks, if I'm up too long, my socks aren't fitting, they're tight, and I can press in my leg and see a dimple, indent. These are probably the main signs. Now, other things can happen here. Some of them would be, Doc, my heart's been racing. So as the heart function gets worse, to make up for the lack of function, it will increase the heart rate to get more blood out. But also, as the heart fails, you will get arrhythmias such as atrial fibrillation, which a lot of people know about, where the atrium doesn't work and the heart just beats crazily, maybe 150, 160 times a minute, and that's not very good. So we see this kind of thing also. And then finally, heart failure can look just like a heart attack. And people who present sometimes with shortness of breath are doing so in the midst of a heart attack, and they don't get chest pain, they get shortness of breath. So it's another reason we say the people worried about heart attacks say, if you're short of breath, get to the hospital. Now, one of the biggest causes of heart failure, if I see new heart failure, I say, well, gosh, you don't have hypertension? No. You haven't had any recent virus, have you? Because there can be an infection of the heart. No. Are you a big drinker? No. Well, let's figure this out. Your cholesterol's high, and you mentioned that you get some pressure, some discomfort in your heart, in your chest. Yeah, Doc, it's been getting a little worse, but I rest and it goes away. Well, did you ever have a time when it didn't go away? And then you find out 4 weeks ago, oh gosh, it was after I went to the gym and lifted weights, and it felt like one of those weights were sitting on my chest, and it lasted all night. And I was going to go to the doctor. I was a little sweaty, nauseous. I felt better. And so I didn't go. But it seemed after that when I started noticing things. And there you have it. Right now you can be sure they had a coronary artery blockage, an occlusion, a heart attack, and enough of the heart muscle died from that artery being blocked that they developed heart failure. And that's why the two are so tied in.
Dr. Maisel, if one is able to diagnose heart failure early on in the progression of the disease, does it have a benefit for the outcome? Do people do better?
This is definitely the case, and this is why we're trying to raise public awareness of heart failure. In fact, recently, there has been a revised staging system for heart failure. We now have what's called A, B, C, and D. Stage A, you do not even have heart failure yet, but you are at high risk of heart failure, but no disease and no symptoms. People that are stage A are those with obesity, with hypertension, with diabetes, things of this nature. We put it at stage A because we say, look, if you treat this now, you will prevent the development of symptomatic and structural heart disease. And there is definite evidence. There's a relationship between people who modify their lifestyle factors that I mentioned and the heart failure risk. And you can take that heart failure risk and the highest risk from 20% and move it all the way down to between 5 and 10% over about a 5 to 10 year period. Now, so this is fantastic news.
Dr. Maisel, as we sum up, what is the message you would like our listeners to take home? First of all, what are the symptoms they should be alert for when it comes to congestive heart failure?
Well, I think symptoms of heart failure, really shortness of breath. That's just not your normal way. Maybe you have a cold, but the cold doesn't get better. That could be an infection of the heart, swelling of the heart. You can't lay flat. Early urination that's not at night, that doesn't have to do with prostate. Those should bring you into the doctor. We believe while primary care can manage heart failure once it's stable, a cardiology needs to get in on this. Cardiologists, we know how to use the new drugs. We know in what doses that will be best for the patient. We know how to monitor the patient with the biomarkers. We know what advanced therapies are available with catheters, with other kinds of devices that we can use, even on the road to transplant. We know the latest what's coming with stem cells and genetic therapy. We also know that we can reassure the patient that we can improve function almost all the time. Sometimes we can get them off some of the medications, but others are for life. And also, there are some patients that we need to talk to about palliative care, those that are really on their last legs, where the heart failure has just got the best of them over time, might be 10, 20 years, and they're just tired of not being able to walk, the medications aren't working. Those conversations, power of attorney, do we turn the defibrillator off at some point? What do we do? Hospice. And I think when you right out front with the patient to let them know that, look, if things don't go well, we're there for you. We're not gonna let you suffer. We're not gonna let you be shortness of breath. We're gonna get you what you need, maybe even in your home. But short of that, we can extend your life for years and years. Not only extend your life, but make you feel so much better. So I think the crystal ball shows us a lot of fantastic hope if you have heart failure.
Dr. Alan Maisel, thank you so much for talking with us on the People's Pharmacy today.
Well, thank you for having me.
You've been listening to Dr. Alan Maisel, Professor of Medicine at the University of California, San Diego, and Director of the Coronary Care Unit and Heart Failure Program at the Veterans Affairs San Diego Healthcare System. What you've just heard from Dr. Maisel was extracted from a longer interview, and if you are interested in heart failure, you'll find the entire interview at peoplespharmacy.com.
We spoke earlier with Dr. Rita Redberg, Professor of Medicine at the University of California, San Francisco, and editor of JAMA Internal Medicine. There are links to her articles on statins and saturated fat at peoplespharmacy.com.
You also heard from Dr. Steve Nissen, chair of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic.
Lynn Siegel produced today's show. Al Wadarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible in part by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. 800-345-7339. Online at uttercream.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1085. That number again, 800-732-2334. Online at peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your thoughts on today's show. We'd love to know what you think.
At our website, you can also sign up for our free online newsletter or the free podcast of the show. You can listen at your own convenience or share it with a friend. We'd certainly appreciate your rating our podcast at iTunes, Google Play, or wherever you subscribe. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.
When it comes to Father's Day, dads want steak. And the experts at Omaha Steaks are making it easy for you to deliver uncompromising quality with gifts that are sure to make his day. Plus, get an extra $35 off with code THANKSDAD when you shop at omahasteaks.com today. But don't wait. Father's Day is June 15th. Shop now at omahasteaks.com and get an extra $35 off with code THANKSDAD. Minimum purchase may apply. See site for details.